Um, we should probably get started now. Okay, so thank you so much, everyone, for joining today. My name is Christina, and this is Kerry. Hi. And we're both from Craniofacial Australia. And on behalf of board and staff of Craniofacial Australia, we'll welcome you to our first session of Cleft Aware. We are absolutely honoured to be partnering with Dr Jessica Boyce for this series of webinars. And for those of you that don't know, Craniofacial Australia is a not-for-profit charity. We were established a little over 40 years ago by Professor David. And our mission is to support and empower people living with craniofacial diagnosis, including those with cleft lip and palate. And just a little bit of housekeeping, this webinar will be recorded for future reference. So we'll have it available as a resource on our website. And Dr. Boyce will also be authoring a series of brochures along the lines of these topics and a couple more. And those brochures will be available as a resource on our website as well in the coming weeks. So if you're not already following us on social media, definitely suggest following us just to keep in the loop, and that'll let you know when everything's available. And I also wanted to acknowledge the generosity of the PKF Foundation in Adelaide. So we submitted a grant and received a generous funding for this program for Cleft Aware. So on behalf of the craniofacial and cleft affected community, thank you PKF Foundation Adelaide. And I now pass you over to Dr. Boyce. Thank you, everyone.
Thanks so much, Christina. And thanks to Craniofacial Australia as well for putting this together. I really hope that it will form a wonderful and useful resource for everyone here tonight and everyone who might watch in future. Thank you all for joining live at this time. I know it's a challenging time for those, especially with young people at home. So I really appreciate it. So as Christina said, my name is Jess. My background is in speech pathology, and I have a special interest in cleft lip and palate. So I'm really delighted to be here with you tonight and over the next few weeks to talk about different aspects in the early years and how you might support your baby or your child who's born with a cleft. And before I get started, I'd like to acknowledge the traditional owners of the land that I'm on today. I'm at home, the Wurundjeri people of the Kulin Nation. I've had the privilege of living on Wurundjeri land for over 15 years now, prior to which I was in Hong Kong. I'd like to pay my respects to the custodians of the land, their elders, their families, past, present, and emerging. And Christina mentioned that this is being recorded, so thank you. I can see everyone's on mute. Thanks for keeping yourselves on mute. The chat box is enabled, so if you have any questions that come up that you think of as I'm talking, do pop them in the chat box and I will get through as many as I can at the end of the session. I do want to flag as well that what I'm discussing today is general in nature and intended to be educational so that you have an understanding of what's happening anatomically, structurally, and what needs to happen for things to occur successfully, I suppose. And so that you can best then take that information to support and advocate for your child. Each family, of course, has individual needs. So please take this information as a general guide and take what you think is useful. And if there are parts you think are not so relevant for you, leave those behind. And do speak to your child's team with any individual concerns. So today, as you can see from the slide here, I'm going to be talking to you about feeding your baby. And in the next 3 sessions, I'll be going through speech and language development at different time points and how you might best support your child in those areas as well. I'm mindful that there are many stages of feeding a baby with the cleft, or feeding any baby. Welcoming a new baby into your family is such a huge time, a huge adjustment, a huge period of change. This is a really big topic. We've got a short amount of time today, so I'm going to briefly cover a range of different stages. And I'm really going to focus on what's unique to cleft. So I'm not going to talk about or go into as much detail about the general concepts around early feeding. So wherever you are in your feeding journey, I hope you're able to take something away with you from today. So let's get started. Oops. Okay. So I'm going to spend a little bit of time now talking about how clefts impact early feeding. And then second half of my talk today, I'm going to be moving into a few key strategies that might be helpful for you to consider. So the main challenge when feeding babies with clefts, the main challenges occur before surgical repair. But there's also, of course, going to be a period of transition after repair as well. Most of what I'm talking about today is relevant to that pre-surgical period, but some things may flow on as well. So let's have a brief look at what's happening anatomically. So here we have a lateral or side view like this. And this might look a little bit technical, but I want to go through this and give you this background because I think that if you have a clear understanding of what's happening anatomically, it will be easier for you to adapt strategies and select feeding tools, adjust positioning based on what suits you and your baby best, because you will know your baby, you will know yourself, your own body, what you have around you and what's available. So if you understand what's happening anatomically, I think you'll be better equipped to adjust things to suit you best. So we've got, I think you can see my mouse here. We've got the nose, the lips. This is obviously an adult here with teeth, just so that's a bit more familiar for you. So nose, lips, hard palate here. This white part is the bone, and then the blue part here is the soft palate. That's the muscle. So when the baby is feeding, they need to have a seal around the nipple or the teat. And that is the first step to then generate pressure inside the mouth to allow the milk to be extracted and then swallowed. So for this to happen, if we move over to this diagram on the right, the soft palate rises and the posterior pharyngeal wall, this wall at the back here, moves forward. And there's a tight closure at the back, or that's what we want to be happening. So if we have a cleft lip here at the front, that can affect anterior attachment. So how the lips close around the bottle teat or around the nipple. And then if we have a cleft anywhere along the hard or soft palates, that's going to affect a baby's ability to generate pressure inside their mouth. And that's going to affect how much milk can then be extracted and then where that milk goes once it enters the mouth. So whether we want the milk to be going down here, down the esophagus to be swallowed. But if there's a cleft anywhere along here, there's a chance that the milk might come out through the nose as well. So when we're thinking about the palate here inside the mouth and where the cleft is and how big it is, there are two components that we're considering when we're thinking about successful or effective feeding. So the first one is the structure of the palate. So where the cleft is, how big it is, and that's going to affect those two things I just mentioned. And then the second thing is what's happening at the back here. So at the back, right at the back of the mouth, is the palate able to rise and close at the back? And I mention that because sometimes we have more subtle clefts or smaller clefts where there might not be much milk escaping through the nose, but there's more a challenge here at the back where we're not getting a tight closure, and that can affect how much milk is extracted and also where the milk goes as well. Okay, so that's those two areas and components that we're thinking about when we're thinking about what's happening on the palate. Okay, so hopefully you're forming a picture in your mind now of what's going on and what needs to happen for successful feeding. So summarizing the main challenges or difficulties that might be happening here, it's that babies with clefts in their palate have trouble generating enough pressure in their mouth to draw milk from the breast, chest, or bottle. And there are a number of factors that might affect this. So what type of cleft it is it in the lip? Is it in the palate? Which part of the palate is it in? How big is it? Is it on one side? Is it on both sides? And then within that, how big is the cleft? And as you would expect, we tend to see more difficulties with babies that have larger clefts, but that's again going to depend on where it is. And then age and maturity is another one. So as the baby gets older, they're likely to have more success at drawing milk out. So things change when babies grow, their anatomy changes, they get stronger, they learn, you learn, and we see more success as the baby grows and matures as well. So on this slide, I'm going to go into a little bit more detail and some notes here as well on the different cleft types. So it is likely that your baby will be able to receive adequate nutrition orally, whether this be directly from the breast or chest or through a specialized bottle. But caveat, I suppose, is that this will depend on a number of other factors like the general health, how many weeks they were born at, if there are any other medical or health factors that are in play as well. So briefly going to go through the broad differences in different cleft types here. So, and this is a recap, I suppose, of what I've already touched on. Again, flagging the important concept, we're thinking about what happens at the lips and then what's happening inside the mouth. So with babies that have a cleft lip, we're focusing on that lip area. So what's happening there? So typically it's that initial seal around the nipple or the bottle where we see challenges for those who have a cleft lip. And typically they're able to generate enough suction within their mouth to feed well. And sometimes if you're using a bottle with a wide base teat can be helpful. But again, it's going to depend on the size and the location of the cleft. So babies with a cleft in their palate, they can, if they have a cleft in their palate only and no cleft in their lip, they can close their lips around the teat or the nipple really well. So sometimes from the outside, it can look like they're doing well with their feeding. We can't see anything that looks like it might be causing any challenges before feeding starts. But as you now know, the challenge is what's happening inside of the mouth. So they might not be extracting enough milk, or the milk might be escaping through their cleft out of their nose instead of going down into their stomach. Having said that, some infants with small clefts in the soft palate, so that blue muscular part of the palate from the earlier diagram, may be able to generate enough suction on their own. But more often than not, they will need a bit of help to draw the milk into their mouth. And that's going to be similar to babies with both a cleft of the lip and palate, but we're also needing support around that more anterior attachment as well. And just briefly touching on a submucous cleft palate. So a submucous cleft palate is a type of cleft palate where we see a break in the underlying muscles, but if you have a look inside the mouth, you don't see any overt cleft. It can be hard to diagnose, but I'm putting it here because sometimes feeding difficulties are the first sign of a submucous cleft palate. So the challenge that babies with a submucous cleft palate might have is getting that tight enough closure at the back. So they don't have any clefts in their palate, but because there's a break in those soft palate muscles, they're not able to get that tight closure at the back of their mouth or throat to prevent the milk from escaping out through the nose or to generate the intraoral pressure that they need. Okay, so that is that for the first section. So how does cleft impact feeding? This is what we're looking at. So what can we do? What kinds of things can we do to support, and how can we then go on to feed our babies? So depending on the type or the size of your baby's cleft, you can feed them directly at the breast or via a bottle with formula or express breast milk. Bottles or syringes, as you can see in this picture here, are typically more common because of the reasons that I've mentioned. And this time, if there are other caregivers around supporting caring for your baby, it's a wonderful time to have others involved as well. So you can try out different things together and work out what's best for you and your baby. So what are we thinking about here? So particularly before surgical repair, one of the main things to consider is the role of gravity. We want the milk to flow to the back of the mouth and down the esophagus, rather than up and out through the cleft. So it can be helpful to hold your baby in a semi-upright position so that the cleft is oriented upwards or towards the top of the breast or bottle. So generally, a more upright position is good for this. So if your baby has a unilateral cleft, think about orienting them in a position so that cleft is towards the top, so that the milk extracted can then flow. Gravity can help it flow in the direction we want it to. And for a bilateral cleft, again, we can think about gravity, and we might be thinking about more of a face-on straddle position. That might be a little bit more effective. So you might just try out a few things to see what works best for you and your baby. We want to be finding a place that is comfortable. Ideally, we want a calm and quiet environment so that you can focus on your baby, but of course that's not always possible, especially if there are older siblings running around. But a place where you feel comfortable and you feel calm and you at least can give your baby a little bit of focus time while you work things out. We really want to be following the baby's lead. So if they're comfortable, if they have a rhythm in their sucking, keep going, continue as you are. If they're unsettled, if they're upset, give them a little break, stop. Everyone take a deep breath. You might like to readjust your position. You might like to adjust the pace of how you're squeezing the bottle. If you're using a bottle, try again. It can be challenging when there are so many things going on, when you're thinking about all of these strategies and ideas that you've been told to apply and use. It can be really challenging to follow your baby's lead in this moment. But with time, and if you're able to really focus on them, you'll find that they will be telling you what they want, what's working, what's not, and then you can go from there. Something else to think about, which I've mentioned a few times already, is the position of the nipple or the teat. Typically, we want that to be away from the cleft, especially if it's a palatal cleft. So you think about where you're directing the milk. We don't want the milk to be directed into the cleft because then it's going to come out the nose. So directing the milk away from that cleft. Depending on the position of the cleft and your positioning when you're feeding your baby, you might also like to use a thumb or a finger to occlude the cleft or support their cheek. Again, there's going to be a bit of trial and error here. And then another thing is to make sure you take breaks for burping during each feed. Your baby might be swallowing extra air through their cleft. So giving them time to taking a break and allowing them time to burp will also help them keep the milk down. So that's something that's easily incorporated, I think, into your routine. And you'll start building an understanding, and you'll be able to read your baby's cues to know when you might need to take that break, or if burping is something they might need a little bit more of. So if you have a grasp of your baby's anatomy and what's needed to then to extract the milk and swallow it, you can try out some of these different options to see what works best and what's most effective for your baby. So of course, there's going to be a little bit of trial and error. And your baby will also change as they grow. So it's important to be flexible and adaptable, as challenging as that is. So depending on where you are in your journey, these bottles may be familiar to you already. So these are just some examples of some specialized bottles. The Cleft coordinator at your hospital or the Cleft specialist nurse can show you what's available and where you might purchase them. The main features of these bottles is that they help the milk to flow. So the teats are different shapes, and you can see they're different across the different bottle types. And they allow you to position the teat away from the cleft, or adjust that positioning as you see fit for your baby. They're also squeezable, so that allows you to help your baby get the milk out by squeezing. You can squeeze the bottle, or on some of them, you can squeeze the teat as well. And that gives you control of what's happening. And most of these bottles also have one-way valves to control the flow of the milk. So as I mentioned before, we want to be aiming to keep the baby as upright as possible to prevent the milk from dripping out of their nose. Around 45 degrees is good. We want to gently squeeze the milk into the baby to the baby's mouth once they start suckling. So we might do one squeeze for every 3 to 4 sucks, but again, you will adjust this and adapt it according to your baby. If you're trying out a new bottle, it might be helpful to practice to put some water in initially and just see how much water actually comes out when you squeeze it, so you know how hard you should be squeezing on the bottle. So which bottle you choose might depend on what you have available, little trial and error. There's no one size fits all. So it's really important to adapt and try different things and just use what works best for you. So I've been talking about milk so far, but the introduction of solids happens really quickly. So you'll be focusing on this, and then suddenly your baby's 5 or 6 months old and it's time to think about solids. So babies with clefts can usually start solids around the same time as any other baby, so around 5 to 6 months. So if we think back to the anatomy and what's happening here, we might again see food or drink coming out of your baby's nose as they try new things. So again, an upright position is going to be helpful, but that's probably what you would naturally be doing anyways when we're thinking about food and drink. Thinner or runnier foods may be easier initially. Again, fairly a bit of trial and error, I suppose, with that one. If you notice, depending on the general type of approach that you want to take with how you introduce solids to your baby, if once you start this process, you notice a particular type of food or a particular texture of food coming out of your baby's nose more frequently, it can be helpful to note down what that is, and then you can take that back to your cleft nurse or your speech pathologist and have a bit of a chat about what might be happening there. Okay, that's showing where the food or drink might be going. All right, so different hospitals and surgeons will have different protocols regarding feeding after surgery, and the cleft type and general health is also going to impact when feeding can recommence after surgery. There's generally a short period where doctors will recommend no eating or drinking, but overall, if there are no complications, feeding can recommence relatively quickly. after surgery, smooth or pureed diet is going to be recommended initially. But this is very much general here. It's going to be important to go with what's recommended in your specific hospital and center, where the individual needs of your baby can be taken into account here as well. So coming to the end of my talking today, I want to recognize that the period when you have a baby, new baby joining your family, is a huge period of adjustment. There's lots of learning on all fronts. So it can be extremely challenging on top of lack of sleep and everything else that comes along with this chapter of life. But I hope you leave today feeling a little bit more informed with some tools in your toolbox, maybe even some questions that you can bring to your next appointment. But in the meantime, if you're looking for some more support or guidance, here are some places you can go. So there are obviously your health services, hospital-based cleft clinics, cleft nurse specialists. If you are looking for community or private speech pathology clinics specifically, you can go to the Speech Pathology Australia website, and you can just Google Speech Pathology Australia, find a speech pathologist. And then you can do an advanced search and look for clinicians that have particular expertise in cleft. As Christina mentioned, we'll be putting together some written brochures that will go alongside what I'm talking about in these webinars, so you can access those online as well. They'll be available in the coming months. And then there are lots of wonderful family support groups that provide that connection and support through events, welcome packs, and things like that are all around the country. So we have Cleft Pals across a few different states, Craniofacial Australia, of course. And then if your baby has other diagnoses, there are some specific foundations like the 22q11 Foundation or Pieroban Australia. That brings us to the end of today. So I think there are some questions in the chat, which I'm going to try and have a look at now. But I just wanted to again thank PKF Adelaide Foundation and Craniofacial Australia for putting this together. If you are if this is the only webinar in the series that you were planning on attending, would be really grateful if you could use that QR code on the screen there to fill out a brief survey. If you're planning to come to others, you can wait till you've come to all and just fill it out once. So let me just thank you for bearing with me while I just have a look at the chat. Great. Well, if I've missed anything, Christina, you can let me know. Otherwise, we might leave it there. Thank you very much. And I look forward to, if you are joining, seeing you again in 2 weeks to talk about speech and language development in the early years and the links with the surgery timelines. I think you're on mute, Christina.
Thank you. I was just saying thank you, Dr. Boyce, and thank you to everyone that's joined us today. And we look forward to joining forces again in a fortnight on Wednesday, the 19th of February.
Wonderful.
Great.
Thank you.
Thanks, everybody. Have a lovely evening. Thank you. Take care. Thanks. Bye. Bye-bye.